Hi, all. We're just going to give it a minute or two to allow everybody to sign on. Thank you for your patience. Good morning or good afternoon, wherever you happen to be. We're just going to wait 1 minute and then we will get right into this. I want to welcome everyone to today's Research Alliance discussion. I'm Ashley Arabasadi, and I'd like to thank you for joining us on Zoom today from wherever you happen to be, and for your partnership in the Research America Alliance. I hope everyone is looking forward to the discussion as much as I am. First, a little administrative housekeeping, if you'll allow me. If you aren't a member, I do hope you will consider joining. Our director of membership, Joel, we can drop his email in the chat, and we would love to talk to you about joining the Alliance. But today we're joined by Dr. Dan Jernigan, the director of the National Center for Emerging and Zoonotic Infectious Diseases, or NCEZID, at the Centers for Disease Control and Prevention. We've asked Dr. Jernigan to discuss the new vision for NCEZID and how the center is incorporating innovation into its mission. As always, we encourage you to please type your questions into the Q&A box or chat, and we'll pose as many as we can during that portion of today's session. Thank you so much for joining us, Dr. Jernigan. I'm going to hand it over to you for your presentation.
Great. Well, thank you very much for the opportunity to speak. Really appreciate being invited by Research America Alliance, and so look forward to providing you some information about us and also just from taking some questions from you later on. So just a little bit about me. I actually am starting or have started in February of this year as the permanent director for the NCEZID, the National Center for Emerging and Zoonotic Infectious Diseases. And so that is one that I came to after being at CDC for a while. I started in 1994 as an epidemic intelligence service officer in the respiratory bacterial pathogens group. And then from there, worked at the Washington State Health Department for a while, worked in hospital infections at CDC for a while. I was in influenza for about 15 years, and then was the director of the influenza division during until 2022, and then have eventually made my way here to the NCEZID director position. So really honored to be here and glad to be learning from you and working with you at Research America Alliance. Let me just go to the next slide. Let's see, hopefully these things will work here. There we go. So there are a number of things about emerging infections that folks are probably familiar with, but there's really three components I think that are important for us to remember. And those three components actually have implications for a number of the divisions that we have within NCEZID that service multiple different aspects in terms of research and implementation and public health around emerging infections. The first thing is that the world is increasingly crowded. And so these pictures here are from Mexico City, from Shanghai, from New York City. There is an anticipated 11 billion people by 2050. 80% of this change in terms of numbers has occurred in less developed countries. And most of this change and this increase has been in these, quote, mega cities where there are greater than 10 million inhabitants. Things like Mexico City, 22 million, Shanghai, 29 million, Dhaka, where we have had studies in the past, in Kamalapur, which is an area there with 288,000 people per square mile. So these kinds of environments are ones in which it allows for rapid acceleration of an emerging infection if it were to emerge. The other is that the world is increasingly connected. One can travel to almost any major urban center in the world within the incubation period of most infectious diseases. That's something that people have been saying for a long time, but I think it really comes in into focus now after COVID, where everybody understands this concept now. There are about 2.75 billion airline passengers globally, and within our center, we manage the Division of Global Migration and Quarantine, which actually oversees the quarantine stations and takes care of refugees and folks that are migrating into the United States. not only is there connectedness with people and airlines, et cetera, but there's also connectedness through supply chains. America imports 50% of its fresh fruit, 80% of seafood, 80% of active drug components. And so it's important for us to understand what's happening around the globe and to monitor things in the United States to detect those problems. And our Division of Foodborne Water and Environmental Infectious Diseases, called DFWED, that group in our center helps us to manage those things and works with other countries in supporting their improvements in those areas too. A third component is that the world is increasingly converging. And by that, I mean that the worlds of humans and animal populations are converging with the environment, converging between livestock, but also wildlife. There are growing populations in megacities along with rising consumption of meat. The chicken is now the major source of protein in those urban settings. And what we have then are the actual production of chickens and swine within urban populations, sometimes in the same space with tilapia ponds and other things as well. So those animal dense productions are happening within those urban areas and can lead to spillover events, not only from wildlife like you see below, but also from bringing them into live animal markets. Again, everyone very familiar with that because of COVID. So those three components are really coming together to make emerging infections a ongoing problem and an accelerating problem as well. As an example, the Marburg virus event that we just had a couple of months ago is one of those. If I don't know how many of you knew where Equatorial Guinea was before this, I had to look it up myself. The map of Africa there shows you where it is. The call out to the right shows you the rectangular region there where it says Equatorial Guinea. Up in the right part of where it says Abyei was a place where there were cases of Marburg virus disease among people living in the forested areas there. So it's a type of Ebola. It's transmitted by these bats that you can see the picture of there. There probably is a cyclical nature to that. But when there was a few cases, we actually did send a team there. They put a lab within a week and a half of hearing about this event, had that team there, set up their laboratory, began PCR testing, and were able to transfer that technology to the Equato-Guineans, it's another term I learned, to those folks there in Equatorial Guinea so that they could do that testing. There were cases then that moved over to Bata, which is that urban area along the coast, which is also where Exxon and other companies that do oil in the region have their base. And so it's important to keep these infections out of those urban areas so that spillover occurs, it can get to that urban area, and then it can get to where it can be connected elsewhere in the world. So for us, getting there early, helping the country to stop that before it happened, working with USAID and other partners to do that, and using new technologies and transferring that technology. There are lots of complications here. I don't know if how many of you know where the capital of Equatorial Guinea is, but it's actually on the island up to the top there. And so it's a very complicated area. Native Spanish speakers, the only ones that speak Spanish in Africa. And so for us to get that team there with the right people and the right skills to do the right thing was something that we were able to do quickly, but it's the kind of work that we do in NCEZID. So with us, we are protecting people and preparing for infectious disease outbreaks. There's a number of activities that we do within the center. We have the Office of Advanced Molecular Detection. It's a very large amount of funding that goes out to public health labs, to centers for excellence, to do both research as well as to improve capability and capacity for next generation sequencing. It is now 10 years since we have begun that program, and we've had some tremendous successes in bringing that sequencing capability. I'll talk a little bit more about that in a second. We have vector-borne diseases, our laboratories in Fort Collins, where they do both research and applied evaluations and animal work. That group there does dengue and Zika and West Nile virus, as well as Lyme disease and other tick-borne diseases like Rocky Mountain spotted fever. We have a division of healthcare quality promotion that does antimicrobial resistant infections, a very large funding program that goes to both academics and to state health departments and to others to do implementation of infection practices, as well as stewardship for antimicrobial resistance, and also it helps support research as well. We also have a division of high consequence pathogens that manages those deadly diseases like Ebola and Nipah, anthrax. We have the division of foodborne, waterborne, and fungal diseases that I mentioned earlier. That group does E. coli, salmonella, as well as cholera, cryptosporidiosis, and fungal diseases like the emerging Candida auris. And the most recent investigation occurring right now with liposuction-associated fusarium fungal meningitis. So people going down to Mexico on medical tourism, getting injected with contaminated anesthetic, and then getting fusarium meningitis, a type of fungus. About 8 deaths so far out of 200 people that received those injections. We have our division of global migration and quarantine, like I mentioned, with 20 quarantine stations around the globe. And we have the epidemiology and laboratory capacity grant process, which is a way of investing in state and local capacity. It is a cooperative agreement that over the last 3 years has distributed about $43 billion, that's with a B, because of the COVID response, in addition to a whole lot of other things that we've been doing over the last 3 years. The center also manages the One Health office. The center's NCEZID serves as the agency lead for the One Health activities domestically and globally. So within the United States, we help manage the new National One Health framework, which has been mandated by Congress to have the federal government work together on One Health issues, but also advancing One Health globally through the provision of individuals that actually serve on deployment in places like Tashkent, Uzbekistan, but also providing technical assistance to One Health activities, looking at how we work together from an agricultural side, from a human health side, and from an environmental side as well. In terms of priorities for the center, one of the requests for the talk today, we certainly have been hearing from a number of folks outside of CDC who have developed recommendations on how CDC should be addressing some needs that have arisen because of COVID. Recommendations like improving transparency, building back trust, being able to do data correctly, getting your laboratory work done correctly. All of those things, I think we have heard and have, through our director, developed a moving forward initiative. And within our center, our highest priority for that is strengthening infectious disease response readiness. Those break down into 4 components: operational readiness, enhanced data systems and data readiness, laboratory readiness, and global response readiness. And so I'll talk about those 4 things here just to give you a sense about how it is that we're changing, both from a structural standpoint through reorganization, but also functionally in terms of how we're organizing our work to make us quicker and more targeted. In terms of operational readiness, there have been a number of efforts to support responses like Mpox, COVID-19, Ebola Sudan, just within the last 3 years. Those have highlighted the need to achieve more standardized and structured responses. So as a center and as an agency, we are actually developing cadres of staff that are ready for responses, cadres like those that do infection prevention and control, those that do global migration and border issues, those that work on behavioral science issues, those that are communications, et cetera. So we are organizing our center in order to fulfill that need that those cadres will do during responses. We've been innovating pathogen agnostic approaches for surveillance like wastewater, and I'll talk a little bit about that. Developing plans for prioritizing non-response work, that is, if we have a big response, what are we not going to do? And assessing program capacity for areas regularly involved in infectious disease outbreak response as well. So that operational readiness also, structurally, we have a new lead that's over that operational readiness activities so that we can coordinate our responses more quickly and have a more scalable approach. In terms of data systems, there's a lot at the agency. I actually served leading the data modernization initiative for a period of time, and the agency is moving into the cloud. It is actually looking at different ways of utilizing enterprise-wide solutions to our data needs and implementing reusable components that can be easily scaled up during the response. So that's putting standards in place, making sure that we're using common elements when we're requesting and gathering information from our public health partners, and implementing a common operating platform. Sometimes people call that a common operating picture for scalable responses. For that, we have a new platform called READY, which is Response Ready Enterprise Data Integration. That's utilized as a Palantir platform. It's the same as HHS Response that was used during COVID. And so CDC maintains that interagency USG-wide common operating platform for health emergencies. We use the same one for our small outbreak investigations now as well. And so it can then scale up so that if we have a small Marburg outbreak, we could do a large one without having to change the systems and come up with new approaches. In terms of laboratory readiness, certainly CDC has a long history of doing a lot of laboratory work. There were some issues around the tests that were developed early in COVID, and we are addressing that across the agency, but within the center also by developing a new laboratory assay readiness office. That group, you can think of them as essentially holding the hand of a subject matter expert in the laboratory so that the subject matter expert, the laboratory, does not have to understand FDA 510K application processes or design control or document control. That's being handled at a level higher so that the individuals can focus on the test performance. We also know that tests need to be done on common platforms so that if we develop a test, it can be easily transferred technologically to Quest or to LabCorp or to others, or it can be brought through to FDA 510K or EUA during an emergency if needed. So that's all in the context of also looking at laboratory quality issues as well. In terms of global response readiness, we're continuing to prioritize our activities that are needed to protect the US from global health threats. We've developed global health priorities, really looking at viral hemorrhagic fever, dengue, IPC, AMR, foodborne, and others, and sequencing rollout globally as important components, including the identification of staff that will be in strategic locations and in CDC regional offices to provide technical assistance for these areas that I just mentioned. So those are all things that are now being coordinated out of a new global response office within the National Center. And Paige Armstrong is our new lead for that activity. But we have also recently, as a part of the CDC reorganization, which was announced publicly, we will be receiving the Division of Parasitic Diseases and Malaria. And I'll talk a little bit about that in just a second. So in terms of ongoing innovation, there are a number of things happening. This is a picture here of an individual in our BSL-4 environment, looking at micronewts, trying to see the impact of particular new experimental pharmaceuticals and countermeasures to see how well they slow the growth of different viral hemorrhagic fever viruses. So we're doing those innovations in terms of advanced molecular detection, wastewater, AMR resistance, malaria, vector-borne disease prevention, and countermeasure development. Let me just talk a little bit about some of those things. So certainly, I think most of you may be familiar with advanced molecular detection, but this is a now 10-year activity that has really transformed how public health laboratories are doing sequencing work. Has changed from going to culture first for flu and for foodborne illnesses to starting with next generation sequencing and getting that information earlier, not just for pathogen characterization, but also for the determination of antimicrobial resistance markers, et cetera, and markers of severity. So we have developed pathogen genomic centers for excellence and have developed the Spheres Consortium, which I'll talk about in just a second, but also supporting development of new tools and techniques like software for SARS-CoV-2 sequence data analysis, new testing methods for tick-borne pathogens, applications of these molecular methods for wastewater surveillance. And all of this work is made possible because of that line that comes to us. We are very grateful for that, for advanced molecular detection. And so that's a line that we think has really done incredible things at changing the landscape of pathogen detection in the US and globally. SPHERES is the program which is named Sequencing for Public Health Emergency Response, Epidemiology, and Surveillance. This is a broad engagement with multiple partners that really was a public-private partnership that has informed significantly our understanding of variant COVID pathogens, COVID viruses throughout the response, continues to do that. But also is a platform now for other pathogens so that we can do that rapid collection, coalescing of those sequence data, and then making informed decisions with that data quickly. In terms of our national wastewater surveillance system, we certainly have stood that up for COVID. It is ongoing, continues to be one of the reliable ways for collecting that information on COVID. We have added MPOX to that, and it becomes a very important way of knowing what communities may have 1 or 2 cases of mpox, because we can pick it up in wastewater. And as a part of our director's focus on this fall's respiratory season for COVID, flu, RSV, we look to see how wastewater can expand that information about what's happening with respiratory diseases by looking at what's happening in wastewater. This is a activity that is supported by supplemental funds. And we do look forward to seeing how the emerging infections line, which is a way of supporting those cross-cutting infectious disease issues at CDC, if there are ways to allow that with increased resources to help support a growing wastewater surveillance approach at CDC. In terms of antimicrobial resistance, certainly there are a number of activities happening here. AMR is a big funding source that we provide to state health departments and to multiple others, and it is supported by the Antibiotic Resistance Solutions Initiative from Congress. Investments so far have led to rapid success between 2013 and 2019 with an 18% reduction in deaths from antimicrobial resistance. We would love to have seen that continue, but the COVID happened and a lot of practices and also increased use of antibiotics occurred during the pandemic, but we're beginning to see now those gains coming back so that we can continue moving forward with better stewardship and with decreasing the impact of antimicrobial resistance in the United States. With innovations to slow the spread of antimicrobial resistance, there have been a number of studies and efforts, evaluations like chlorhexidine bathing, as infection control strategies, which was something that was being explored and tested and studied, is now standard of care. Endpoints for decolonization therapeutics, working with FDA to reduce those barriers to bringing new therapeutics to market. And we do look forward to working with BARDA, with FDA, with NIH and others to really see those new therapeutics come through and those technologies that are at a higher technology readiness level to really get them out there for use for things like Candida auris. And then finally, improvements in terminal cleaning of the healthcare environment. So no-touch technologies, sink drains, which can be sources of biofilms, and utilizing metagenomics in order to understand those environments better and how best to control antimicrobial resistance in that setting. There's also countermeasure development that we're doing in our Division of Health of High Consequence Pathogens and Pathology. Our work on orthopox virus diagnostics, the Jenios vaccine, and other outcomes from that orthopox research really led to us having things ready for the 2022 mpox response. And so we really look forward to moving that activity forward, both from a research and an implementation standpoint. Working with others on the Ebola vaccines and looking at effectiveness of those vaccines in settings outside the United States. Working on predictive models for high consequence pathogens, high risk for humans, livestock, and for spillover, taking data from multiple layers and trying to come up with risk assessments that can help us to know where those vaccines should be given. Looking at anthrax diagnosis and also innovative ways of doing diagnostic testing for detection of pathogens, both in human, but also animal samples as well. In terms of malaria and vector-borne disease, this is a screenshot from last night. I don't often get to give a talk where I have a picture from the night before, but this is from NBC Nightly News with Monica Parisi, who's a director of the Division of Parasitic Disease and Malaria in the insectary at CDC, going over what we know so far about the 8 cases in Florida of Plasmodium vivax infection and 2 cases in Texas. We continue to follow that closely, and we'll be communicating findings, working very closely with the Florida Department of Health and the Texas Department of Health as well. There are things happening in that space, new vaccine technologies, monoclonal antibodies, looking at drug development and drug resistance. I think the drug resistance piece is a very important one with regard to malaria. Looking at spatial repellents as innovative ways for looking for means of controlling those vectors. And then not just malaria, but looking also at dengue and others, the use of Wolbachia infection of mosquitoes in order to control those populations, utilizing CRISPR for diagnostics, and then also linking tick bites to meat allergy. And that many of you might know about alpha-gal syndrome, what a terrible disease where you get bit by a tick and then eventually develop an allergy to red meat. That's a very bad thing to have. And so really helping to characterize that from an epidemiologic standpoint, and then working with our interagency partners on how best to characterize that from a more basic science approach as well. So with that, let me just stop. That's a lot of words, a lot of slides, but thank you very much. And then I'll open it up to, I'll hand it back to you, and I'm going to stop sharing my screen at this point.
Thank you, Dr. Jernigan. That was a fantastic presentation. It's amazing to see the variety of work that NCEZID covers. It's actually incredible to keep this all kind of straight. I was taking notes throughout this, and there's been a resurgence of interest in fungal infections, especially as you mentioned by Candida auris. Can you kind of go into some of the associated costs of the lack of cures, kind of the multi-layered problems that's associated with the rise in fungal infections?
Yeah, I mean, there's a lot in that question as well. If you take Candida auris, for instance, I mean, there are still a lot to learn about exactly what's happening there, but for a pathogen that really wasn't around, is suddenly around in a lot of places now and continuing to emerge, but a pathogen that you really don't want to have in a nursing home or in an intensive care unit. And so there may be some associations with temperature and other increasing temperature that might actually play into the emergence of Candida auris. But it does also remind us that there are uses of antifungals on agricultural plants in agriculture. It's very important for making sure that we can have good food security, but at the same time, we don't want to introduce new resistance among various fungi because of what we're doing in order to, with agriculture, that might have impacts on us not having those fungals for use in humans. So I think to your point, there's a real need for us across the interagency and frankly on a global stance with a number of partners to look at agriculture, what's being used, how can we monitor that, and then also looking at what's in the pipeline for new antifungals, and then also just making sure that there's good stewardship of antimicrobial agents, but also antifungal agents as well.
It really demonstrates that delicate One Health balance that you were talking about earlier in your presentation, in talking about decreases or increase of fungal infections among bats, and bats are bats are kind of very influential in our food security, and I don't want to say pollinators because that's obviously the wrong word, but it just goes to show you how interconnected everything is, not only in a kind of shrinking world, but also with these growing issues. So thank you for that. I'm gonna ask a few more questions, and I'm gonna moderate some from the chat. It's very active, so thank you to the audience for being so very invested. I wanted to ask, going back to that kind of public-private partnerships with the CDC, Can you highlight the role of partnerships and collaborations, specifically that NCEZID is doing to enhance public health protections? Are there any examples that you feel comfortable sharing?
Yeah, I think certainly I think AMD is probably one of the easiest to explain. That's the advanced molecular detection, really promoting next generation sequencing and development of new diagnostics. And so that is one of those where it is impossible to do that without working with industry or working with other partners. So for instance, in COVID, we had to work with Illumina and with other sequencing manufacturers and the pipeline of those reagents. We had to understand and work with them on that. There's a lot of innovation that's happening in that space that we can also provide early input on those innovations to help with their development, but also encourage the inclusion of public health activity or public health worth in the tools that they're developing as well. There's the healthcare side of things, the very large laboratories, Quest, LabCorp, et cetera. Those are groups that provide like 45–50% of non-hospital testing in the US. We have to work with groups like that if we are going to be able to detect things and roll out diagnostics quickly. So their participation is absolutely critical. And of course, we do through our vector-borne group, through our AMD group, through a number of other parts. We have centers of excellence that we help support, which is intended to be that connection with the private sector through academic laboratories, but often have components that engage with industry as well.
Well, I did want to note that we have some Alliance members, hopefully even on this call, that were in your spheres slide that we noticed.
Okay,
so just wanted to, I wanted to shout that or foot stomp that. That was fantastic. And thank you for sharing that.
Yeah, absolutely, absolutely critical for them to be a part of the public health team.
I did want to, there's some great questions in the chat, but I wanted to talk to you a little bit about kind of building back trust for the CDC and your kind of approach to transparency and communications, and kind of relate that to data sharing platforms. Is that kind of looking at the way that CDC is moving forward from COVID and incorporating some of the lessons learned? Can you speak a little bit to that transparency?
Yeah, there's a couple things there. One, so CDC is actually going through a process now called Clean Slate. And so that's an activity where we are evaluating our web pages, looking at the content, making sure that they make sense, but also finding things that maybe are not clear or are not helpful or are old. And so that process is really making more efficient the availability of information on our website. There are other efforts as well to get our data out more quickly. So there are requirements at CDC now for when you publish that data has to be made available. And we're developing ways that data can be made accessible, thinking about potential uses of archives, early preprint servers, things like that, but also of places on our website where data is already stored, of making those much more accessible and easier for people to get to. I think another point is around guidance. That we certainly have learned a lot over the last 3 years, and then through the last year of going through evaluation process with support from Jim McCrae and others outside of CDC to help us understand what the approach for improving guidance would be. And I think that while we're still working on that, I think we'll be able to see ways that we recommend things that are not just on or off, but are helping people to understand what the actual risk is, giving them the information so that they can make decisions, and then communicating that in a way that really improves adherence to those, because we're working with the community to develop those messages and working with them to make sure that they're understandable and that they can be implemented.
That's fantastic. Thank you. Thanks for speaking on that a little bit more. I know that was an area that was touched on in our pre-submitted questions, as well as in the chat. So thank you for that. I'm going to go to the chat now. Nicole asks, is CDC investigating pathogen agnostic surveillance to detect disease X, the next pandemic that we know is out there, but we don't know what it is?
So the answer is yes.
Do
we have all of that figured out? Yes, next question. There's a lot that needs to be done there. I think there are different ways of looking at that. There are some like next gen approaches that, metagenomics, et cetera. So that's a space where the work is happening, especially with evaluation of stool for foodborne illnesses. We do know now that nobody's culturing anymore. And if we're going to be able to identify those salmonella outbreaks and do the sequencing of those pathogens, we're going to have to figure out ways to evaluate stool that way. There are also pathogen agnostic surveillance approaches like wastewater surveillance, which if you build it, it's just a matter of switching out your PCR markers. And so that kind of thing, I think, is really important for moving forward on that. There are other approaches, and I'm happy to follow up with you on lists of those if that would be of interest to folks.
That would be great. And I want to stick with wastewater surveillance for a few questions. There's been from Rita in the chat, there appears to be very little wastewater surveillance happening in southern states. What's being done to end the fractured nature of state-based public health research and response?
So there is there's wastewater is happening in southern states, and so if you want to, you can go to our website and actually look at results for COVID at least, and for Mpox on what they're finding. Wastewater surveillance is not everywhere, and even within communities, it's in certain communities based on sewer shed, and so it is not a everything everywhere approach right now, but it does give us important trend information and early detection capabilities. The way that public health occurs in the United States, public health is a state's issue, a state's rights issue. They have the authorities. And so if a state chooses to not do wastewater surveillance, or to not have something be reportable, or to just not report it nationally, that's with those states within the current structure of how we do public health in the United States.
Thank you for that. And sticking with, maybe it's not southern states, but it's definitely the western part of the country, and maybe the southern part as well. Valley fever is of particular interest on the Hill, given how it's predicted to spread. Is there any progress for Valley fever? I know that it's hard to diagnose. And also there might be a visibility or an awareness problem amongst clinicians who aren't testing for this. Is this part of the CDC's strategy moving forward?
Yeah, absolutely. So within the Division of Foodborne, Waterborne, and Environmental Diseases is our fungal disease group, the one that's doing the Candida auris, the fungal meningitis, same group that does coccidioidomycosis. And so that group has a set of activities that they're doing to monitor it. It is reportable disease in certain states, but also we do see that it is an important area for increased awareness, vigilance, and work. And depending on how things happen with congressional decisions, that will determine exactly how much effort we'll be able to put into that. But clearly, an important activity, and one that we think has the ability to continue to rise. Would be happy to have Tom Chiller actually come and speak to you. He'd love that, I'm quite sure, and has a fair amount that's happening in our website. Also has information on that as well on Coxie.
We did. I listened into a discussion that Dr. Schiller had a few weeks ago, which was very informative and also kind of terrifying. So we will take you up on that offer to have him address the Alliance. There's one question from Fabrizio. And how does NCEZID kind of develop novel molecular testing for emerging infectious diseases? Is that private sector? Is it public as well? I think that was it.
Yeah, no, that's a great question. And the answer, we do it actually. We do it often with industry as well, depending on where it is in the sort of pipeline of becoming a more commercial assay. Part of the issue is that so many we have 800 pathogens in the center, and a number of them have pandemic potential or epidemic potential or outbreak potential. And so we are going through a process now of pathogen prioritization, looking at various different factors about transmission and existing capabilities, what platform, et cetera, And then with that, identifying a pathway to development for those that are needed the most. Part of that is to be out in front so that if something does emerge, we'll be ready with that. The way that it's been developed in the past has been rather niche in different groups at the agency. And so, like I mentioned, with our laboratory assay readiness group, we really are looking to change the way that essentially making it a development pipeline or pathway so that the group that understands the virus or the bacteria, they have the idea about what the right sequences are for a molecular assay. They can then provide that, and then within a common framework, platform, reagent, temperatures, et cetera, that we would make assays that are going to be more easily deployable. And deployable sometimes means just us giving it to public health labs, which is the first thing that we want to do and the most important thing we do, but then also providing that to a commercial manufacturer through licensing or through just providing them the recipe and having them in a crisis, but also working with commercial laboratories for the highly automated processes that they have and optimizing those assays so that they can run in that environment. So that's working with them on that. But there's not a lot of money. And so I think, they're not, it's important for us to move forward with it, working with industry and others, but we recognize that this is not an area where there may be a growth market.
I'm going to ask one last question, but before I do want to recognize and acknowledge the chat and the Q&A that there's a lot of interest around COVID reporting, masking requirements, transparency. I don't think we have time to dive into that and kind of state by state and reporting up, but I do want to acknowledge that there's a lot of interest around that as is, not a surprise to anybody. I think if we wanted to have another Alliance discussion focused on COVID and the aftermath of COVID, we could probably think about that. But because it is summer and everyone's summer vacation plans are top of mind, I know you got back from Alaska recently. And Claire has asked the question, what efforts are being made to engage Alaska and the non-continental United States in surveillance using pathogen agnostic sequencing? And she mentions orthopox viruses, but they have limited capacity despite significant risks. So
it's a great question. The reason I was up in Alaska wasn't for vacation. It was actually to visit our Arctic Investigations Program, or AIP, which is one of those programs within our center. It's a laboratory that runs up there doing a lot with vaccine preventable diseases, hepatitis, foodborne diseases, and other vector-borne diseases as well. They do have the capabilities for sequencing, and so certainly are able to benefit from the AMD type improvements that are happening. But Alaska really offers or has a number of issues that really need to be addressed. Climate change is really affecting them. If you think it's affecting us, the tundra is not what it was previously. And so we're seeing that sewers and other things that were buried in the frozen ground are now having trouble. People are having to migrate away from areas where the ground is too soft. It is a population that is rural. It's very difficult for folks to get to them. And so we really see our support through AIP and working with the tribes there and the corporations there to really address those needs, equity needs, food security needs, all of those. It's really an important thing. So from a sequencing standpoint, certainly that as well, but it's in the context of us wanting to work and currently working with them on a number of different issues.
Well, thank you. And thank you for your time, Dr. Jernigan. I'm going to turn this over to my colleague, Jacqueline, to talk about the next Alliance discussion before we end for the day. So Jacqueline, do you want to come on?
Thank you, Ashley, and thank you, Dr. Jernigan, for this wonderful discussion and presentation. I am going to drop the link in the chat for next week's discussion. We are pleased to invite you to join an important candid discussion focused on the art and science of effective R&D advocacy. It'll be next Wednesday, July 26th from noon to 1 Eastern. We'll feature world recognized advocacy expert Bill Novelli. who among his many distinctions founded the Business for Impact program at Georgetown University's McDonough School of Business. And he also co-founded the Campaign for Tobacco-Free Kids and the Coalition to Transform Advanced Care. And he is also the author of Good Business, the Talk, Fight, Win Way to Change the World. Our very own Mary Woolley, President and CEO of Research America, will also join the conversation. And not so successful avenues to greater support for public and private sector fueled R&D, leaving plenty of time for a bit of audience brainstorming. We hope you'll join in with your own thoughts and thoughts on the straightest path to advocacy outcomes critical to the health, prosperity, and security of us all. So thanks again for joining us today, and we look forward to seeing you again soon. Have a great afternoon.